Well, good evening, all. So, Wednesday is focus. So, you got the schedule for focus already?
Yeah.
Yeah. So there are presentations really throughout the week. I know some of you have practices at 4 o'clock, some of them are at 4 o'clock. Softball, none of you play softball, right? No, okay. Softball's gone Wednesday. Baseball, they play today. No, they play tomorrow. And they play Thursday. Yeah,
They play tomorrow as well.
they play tomorrow, yeah. Tennis, when's your guys' next meeting?
Next week.
Next, so you're fine for this
Yeah,
week.
yeah, we're
Good thing I can play this one.
Yeah.
Boy, howdy. All right, so you're required to go to 3 events. I don't care which 3. Pick one, pick 3. Doesn't matter to me. So there's that chap from Oklahoma. I've actually heard him before. He's very interesting. There's that French dude. I don't know him at all, so can't tell you anything about him. Wednesday, there are 6 workshops, I think. There's workshops at 8:30, workshops at noon, and workshops later in the day, something like that. I don't care which 3 you pick, so could be 3 of the main lectures, no workshops. Could be 2 workshops, 1 of the main lectures, could be 2 of the main lectures, 1 workshop. I don't care. I really don't care. Just 3 things, and you go 3 things, and then write a summary. That summary should be brief. By brief, I mean like 500 words. Can't do it in 500 words. You're talking too much.
Are you saying 500 words max?
500 words for each event. So you should be able to summarize it in 500-ish words. So plus or minus 10%. So if it's 426, I won't take out a pen and count every word and then subtract from 42. No, won't do that. I just want you to be able to listen and take notes so that when you go back to summarize what it was you heard, you wouldn't have to sit there and go, well, let's see, I kind of slept through that. No, pay attention in that way. When you write it, you'll know what happened. Can you get these to me, please, within a week of focus? Because if you let it sit, you'll forget what you heard. Yeah.
If we do like any extra, could we get extra?
Yes, you can.
Is there a max?
The maximum extra credit you can get is 40 points. So you'll get 20 points for each essay, each summarization that you do. So the most you can do is 2. If you want to do 5 things, do 2. Hey, I'm okay with that. So it's up to you. You can do how much of this, but you have to at least 3. Okay? Yes, ma'am.
You said no workshop, right?
No, you can go to workshop.
Oh, you can. Okay.
Where did I say no workshop?
My apologies.
Well, I meant to say you can go to the workshops.
Okay.
Oh, you can do no workshops in 3 of the main talks, if you want. Just 3 of something, 2 of this, 1 of that, 1 of that, 2 of these, 2, 3 of these, none of those, I don't care. However you want to slice it up, it's up to you. Now, focus will be Zoom this year, from what I understand. Did I get that right?
Yeah.
So you guys will be able to do this in your slippers. Now, having said that, Wednesday night, we still have class. So yes, we have class, and yes, we have a quiz. Oh, sure. So make sure you come to class next week and enjoy focus. Okay? Any questions about what you required for focus, Emily?
The summary, is that like our opinion of like what we thought of it, or?
Well, it's more, yeah, your opinion, but also what you heard.
Okay,
What you heard. If it's all opinion, then how do I know you're not just, you didn't read the New York Times and you're giving your opinion on the New York Times? At least tell me about what was said. Anything what was said was balderdash, tell me it's balderdash. And tell me why. You think it's the greatest thing you heard since sliced bread? Tell me why you like sliced bread so much. Yeah, or
how long is each session?
50 or 40, 45 minutes, 50 minutes, between 40 and 50 minutes there. There's my bets on that one. The workshops tend to be shorter than the plenary sessions. So, and Q&A, I don't know if they're even gonna do Q&A. You can type in questions, because one year they had this great Q&A and students just submitted questions on little 3x5 cards, and the speaker talked for 35 minutes and then spent 15 minutes answering questions, which is great, because she got to almost every question. Other times, speakers don't really time for questions, so I can't speak for these folks, I don't know. Very good. All right, any other questions about focus? Focus is about liturgy. Before you roll your eyes and say, I'm low church, we don't do liturgy. In fact, we all have a liturgy. Liturgy really refers to a form of worship. So in the Gospels, there's a story about Luke's story is probably a different story. He puts it in Galilee, the other Gospels put it in Bethany, 2 miles from Jerusalem. It's before the Passover, and a lady comes in. John's Gospel identifies her as Mary, the sister of Lazarus. Neither Matthew nor Mark name her, but she busts a really expensive jar of quite expensive perfume and anoints Jesus' head, and other Gospels say also his feet. And then the disciples chew her out for it. This was expensive. This was a waste. This could have been stolen and gone to the poor. And Jesus tells his disciples, in Mark, he words it as, leave her alone. In short, colloquially, back off, man. And then he says, she has anointed me for my burial. She gets what's going to happen. The kingdom of God needs to be ushered in with violence. That is the violent death of the one who is the Lamb of God. And then he says in Mark's Gospel, wherever the gospel is proclaimed, this woman who's not named will be talked about. She worshiped. By taking this very expensive perfume, by breaking the vial, the gift couldn't be taken back. She worshiped and she worshiped with everything she had. That was a form of liturgy, if you will. Figuring out how you will use your life, your job, your whatever, as a fragrance of worship to God, you'll figure that out. That'll be your liturgy. That's what focus is about. So when you think of liturgy, don't think bells, smells, so on and so forth. Yes, bells, smells, so on and so forth can be part of liturgy. But it's much more than that. Much more than that. I was raised Catholic. I know some of you in here are Catholic. And in the Catholic Church, we have lots and lots of rituals. But ask anybody who knows anything about liturgy, they'll say it goes way beyond that. There's a liturgy of the word and then a liturgy of the Eucharist. And then what do you say at the end of Mass? Let us go to. One of you guys is Catholic.
I am, but I don't know what you're referring to.
Let us go to love and serve the Lord.
Okay.
What you say at the end of Mass.
Yeah.
Remember? That's a liturgy too. So now you know.
Right.
I just need to give you more. So give us a chance. Don't just blow it off. Just think liturgy. Oh God, we don't do liturgy at my church. Well, actually, we do. It's just a different type of thing. So, okay. Now, since there are no questions about any or all of that, let's now
I have
go,
one more
go back.
question.
Yes, go ahead, Morgan.
So there's like 2 sessions at like each time, so that's like 2 like, are they gonna be recorded?
The Zooms will be recorded. Now, how long before they get it on the YouTube channel? I don't know. Zoom stuff gets recorded right away. Putting it on YouTube, that's easy. I would think it wouldn't take them that long, but you never know. Yes, ma'am.
As far as the case study, that's due next Wednesday.
Yeah.
So it is coming Wednesday.
Yeah,
You want paper copy, have your turn in?
either paper copy or email.
Okay.
I get the impression you guys are struggling with it. Is that a fair assessment? Okay, here's what we're gonna do. Tomorrow is Tuesday. I will be in the library. My wife works tomorrow, so, while she's at work, I'll be in the library. In fact, maybe, I'll be upstairs in the library. And I'll just sit there and read my Wall Street Journal. So, or something else. If you want to come and chat with me about it, I will be upstairs in the library. You can come, we'll chat. I'll give you as many hints as I think are necessary or legit. Okay, can you guys do that?
Yeah,
What time? 10:30?
Some of us have
AM.
clinical tomorrow, so that's why we're asking.
Tomorrow night?
From morning.
Oh, tomorrow night.
That's tomorrow night. When's your clinical start?
Starts and ends for both is 2 o'clock, right?
2 o'clock in the morning?
It's like 6:40, it's 6:45 till like 2:45, and then 2:45 till like 11:45, right? Yes.
Okay,
Well, no.
now I get a clinical tomorrow night. Four of you? Well, then I'll just be upstairs and then you all can catch me some other time. Okay? Well, morning, good idea of practice.
Oh, no, I thought you said 7:30.
That's too early?
You said AM or AM, right?
No, PM.
Oh, okay.
PM. Tuesday morning, Chuck White gets my butt out of bed and makes me run with him. Couple old men just hanging on for dear life. Don't touch that. No, PM. At that time, I'm puffing at around line length with Chuck. Arguing with him about something. Yeah.
What do you want us to do with our?
Oh, yeah, I don't do that anymore.
Oh, well, I'm not there.
Oh, yes. I'm on the
Yeah, Martin is still playing that street. Oh, look at this economy. Yeah, just, you know. Heck, where's that guy? Good night. What's this now? Yeah.
Oh, I know, right? I'm getting better.
Yeah, let me,
Yeah, she gave it, yeah, pass it forward.
yeah,
So for the dental science seminars, are you waiting to put those grades in until like all of them are done?
I put most of it in.
Oh, I don't know if you saw my email. Like emailed me like a month and a half ago that I watched it.
I thought I put that in. Did you send it from your school email or from,
It was from my school.
because I noticed some students send me emails from their Google accounts or Hotmail accounts or Yahoo accounts or something like that. And for some reason, those go to my spam.
Oh, it should be. Do you want me to like email it to you again?
Yeah, email it to me again, because that way it'll stick. Yeah, curious.
Is it also extra credit if you write or review on one of the science seminars? Isn't that what you said at the beginning of the semester?
You only need to write a review if it's your third one.
Okay.
For the first two, just watch it. Just watch.
You get extra credit for the third one?
You get extra credit for the third one if you go to the third one, because I only require two. But we have three. So if you go to the third one and you attend it and write something on it, that's extra credit.
So we just need to tell you. Oh, sorry.
Do we have a max of like how many things we can?
A map.
A max, like a maximum.
Maximum. Two extra credit
Okay,
divvies.
okay.
Yeah, no.
Where'd it go?
Yeah.
Oh, do we just tell you when we go to the
You
night?
just tell me you went to the seminars, that's fine.
Okay.
You don't need to write me anything, but focus, you need to write about it, because it's different. Okay? All right,
One more tiny question.
yeah.
Sorry. So is it a max of 2 extra credit things like from focus and seminars?
And or this, right,
You can only-
so 40 points. You're like 40 points of extra credit.
Okay.
Okay, ready? Now we're gonna talk about antihypertensives. Go back to the subject. Okay, that's great. Dear Lord, thank you for this cold day, for these students there. Prepare us for focus and this evening. In Jesus' name, amen. All right, so remember, blood pressure is essentially cardiac output times systemic vascular resistance. Either of these goes up, blood pressure goes up. Either of these goes down, blood pressure goes down. So some drugs will attack the problem here. Others will attack the problem here. The best way to decrease systemic vascular resistance is to cause vasodilation. Or reduce blood volume. That essentially is the best way to decrease systemic vascular resistance. So when it comes to cardiac output, the best way to decrease cardiac output is to decrease sympathetic input to the heart. Sympathetic input to the heart releases what neurotransmitters? Oh dear, how far have we fallen? Postganglionic sympathetic neurons release. Okay. Norepinephrine. Norepinephrine, to a much lesser degree, epinephrine. So that means you're going to block epinephrine receptors. And another term for norepinephrine is noradrenaline. Another term for epinephrine is adrenaline. So these receptors are called adrenergic receptors. Adrenergic receptors. So you're going to block sympathetic input to the heart. And the drugs that do that are the beta blockers. Beta blockers. Very good. Last time we talked about diuretics. Now, there's 5 different types of diuretics, but really only 3 of them are used for the control of blood pressure. Blood pressure. Yes, I'll get it. Remember what those are? thiazides, thiazide and thiazide-like diuretics, loop diuretics, and then the third, potassium sparing. There are two other groups of diuretics. We'll just mention them because this is the best place to mention them. They're not usually used to treat hypertension. So the first of these are the carbonic anhydrase inhibitors. Carbonic anhydrase inhibitors. Next are the osmotic diuretics. The osmotic diuretics. Now, we've talked about these already because we saw that there were a couple that are used to treat glaucoma. When we talked about glaucoma, there was benzaldehyde and duraldehyde, zolamide, excuse me, brenzolamide, dorazolamide, they end in zolamide. Zolamide and zolamide, they are a carbonic anhydrase inhibitor. Let's look a little bit at carbonic anhydrase inhibitors and how they work. So carbonic anhydrase catalyzes this reaction right here. Water plus CO2 goes to carbonic acid, and then carbonic acid will disjoin to hydrogen ion plus bicarbonate. And this enzyme right here, carbonic anhydrase, Ca, does not mean California in this case, it means carbonic anhydrase. Since you're producing hydrogen ion and bicarbonate, you can see the importance of this enzyme. This is one of the most important buffers in your body, isn't it? Really, really important buffer. So the way this works in the kidney, this is going to work in the proximal convoluted tubule. And to give you an idea of how these work, let's try to put some color on this thing here. So if this is a kidney tubule cell, so that's a kidney tubule cell, and we're going to put out here, we're going to put a blood vessel like that, and blood's flowing this way. And then out here, this is the filtrate that's made by the kidney. Now, in this cell, you have a little transporter. This transporter is going to take sodium, and it's going to take hydrogen ions, and it's going to move this out here, and it's going to move this in here. So this is an antiporter. It is a sodium hydrogen ion antiporter. Yeah, my writing is terrible. Okay, that's sodium, that's Antihypertensives. Good gravy, that's hard to read. Yeah, I failed penmanship. Okay, so this hydrogen ion comes out here, and out here, it's going to combine with bicarbonate that essentially is in the filtrate. Now, when it combines with this, it is going to produce our old buddy up here. Who's this? What's the name of that molecule? No, this is bicarbonate. You put a hydrogen on this, you get carbonic acid. Carbonic acid. That's carbonic acid. So you get carbonic acid, and then attached to the outer membrane of this cell is our old buddy here. That's carbonic anhydrase. Carbonic anhydrase comes as a membrane-bound form in this cell, and it's going to take this carbonic acid, and it's going to convert it to water and CO2. Water and CO2 can go straight through the membrane because they're water and a gas. So this is going to take this, convert it to water and CO2. Water and CO2 are going to move into the cell. So now you're going to have carbonic gas, these two, in the cell. Now, inside the cell, you have another carbonic anhydrase. This is a soluble intracellular form. So this is a membrane form. This is a soluble form. And this is going to take the CO2 and water, and it will produce bicarbonate plus the hydrogen ion, but the hydrogen ion is going to get recycled back out here. And then this, there's a bicarbonate transporter here. This bicarbonate transporter is going to exchange chloride for the bicarbonate, and the bicarbonate is going to get kicked into the bloodstream. You recapture the bicarbonate that way. This hydrogen ion comes out here, captures another bicarbonate, goes in here, gets disjoined, gets spat out, da-dee-da-da, 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 da-dee-da-da. You're capturing sodium. And then at the base down here, there's a sodium potassium ATPase. That sodium potassium ATPase will kick the sodium back out here in exchange for potassium. Now, what happens if you inhibit this carbonic anhydrase? You keep the bicarbonate and the carbonic acid in the urine because you're going to therefore be capturing more water. This then will get excreted. You excrete this, you also excrete more water. So this also is a diuretic. This will also cause you to excrete more water, and you're going to get rid of more bicarbonate. Now, can you see why you don't want to use this long term? You don't want to use this long term because you're getting rid of bicarbonate. You need bicarbonate. Bicarbonate's a really important buffer. So if you use this for any length of time, metabolic alkalosis is going to be a huge problem. That's why you don't use this long term. When do you use these sorts of molecules, these sorts of drugs? Well, you use them for glaucoma, and then you also use them for high altitude sickness. Now, when you have high altitude sickness, you have more CO2. So your PCO2 goes up, and that PCO2 is going to result in more acid. So you actually have acidosis. By getting rid of CO2, by getting rid of carbonic acid, you treat the high altitude sickness. That is one of the main uses for these carbonic anhydrase inhibitors, is high altitude sickness. So they're not used for blood pressure, they're used for high altitude sickness. And also topically on the eye for glaucoma. All right, any questions about the carbonic anhydrase inhibitors? You think you understand this mechanism here, how this works? It works because you have two different types of carbonic anhydrase, one that's membrane bound, one that's intracellular. And the drug will inhibit both of them. Both of them. All right? Questions? Nope. Okay. Now, what about osmotic diuretics? Osmotic diuretics will cause you to lose water and not a whole lot else. So these are molecules that are not absorbable. So they're at high concentration in the filtrate. And because your kidney will require more water to keep them in solution, you end up losing more water, so you get rid of more fluid. So this includes things like mannitol and glycerol and sometimes sorbitol and drugs like that. Now, when would you use drugs like this? Well, what if you have increased intracranial pressure and you want to get rid of a lot of fluid quickly? You might use osmotic diuretics. What if you have ascites? Remember what ascites is? Fluid in the stomach, usually due to liver failure. Liver failure. Very good. So ascites would be another. You might also have something like pedal edema, where the ankles are really swollen. Athletes. You guys have to have sports physicals before you came to campus? On your sports physicals, did your doctor make you get on the bench and then she picked up your leg and then she felt your ankles to make sure your ankles weren't puffy? Probably because you're younger. My doctor does that to me every time I have a physical. He's looking or she's looking for pitting edema around the ankles, because if you have pitting edema on the ankles, that suggests you have congestive heart failure. So this usually comes from congestive heart failure. So these will usually cause you to lose a good deal of water quickly. That's why you don't use them for hypertension. Because you're losing so much water, they're not the kind of drug essentially that can be used safely. Now, another use for mannitol. In oncology, if you want to crack the blood-brain barrier to get drugs into the blood-brain, into the brain, you can give mannitol with the chemotherapeutic agent. You'll crack the blood-brain barrier and the drugs will get into the brain so you can treat the tumor in the brain. That's a trick you can use with these types of drugs. Big thing to watch with these drugs is A, dehydration. B, usually when you give these drugs, your patient's gonna have a whopping headache. So make sure that their headache gets treated. And then also dehydration, that's the other biggie. With the carbonic anhydrase inhibitors, the biggie here is making sure that you don't overshoot and overcorrect the acidosis so that now you get alkalosis. So you want to make sure that blood pH is properly watched. There is a risk of dehydration as well. Not usually with the doses they're given, not quite as much, but that is a possibility. All right. Any questions about diuretics? Nope. What are some side effects of thiazides? Hypokalemia is your number one concern. What else? Say again. Photosensitivity. Hyponatremia. That's a bigger problem with loop diuretics than it is with thiazides. And because the range for sodium in your blood is bigger than for potassium, hypokalemia is a bigger worry than hyponatremia. Hypokalemia usually will show up first before hyponatremia shows up, but that is a concern. That is a concern, especially in aged patients as well. What else? Blood lipid levels. They can go up. What else? Sugar. They can raise your blood sugar as well. Do you give thiazides during pregnancy? Shake your head. No, you don't. The fluid decrease is not good for the baby. Are there pregnant women who've taken thiazides into their pregnancy? Yes, they have, but they're not recommended for pregnancy. There are drugs for high blood pressure recommended during pregnancy. Thiazides aren't one of them. Loop diuretics, definitely not. Okay, loop diuretics. Side effects. Dehydration. Hyponatremia. Hypokalemia. Hypomagnesemia. Say again? Kidney stones, that's more with the pleuronome. Okay, wrong page, all right. You can get high lipid levels with loops as well. And high blood sugar. Yeah, they don't actually have half-lives that are that long. Ringing in the ears, ototoxicity, but ototoxicity is reversible. As soon as you get off the drug, the ototoxicity goes away.
Obviously, it's like a loop diuretic, but like, doesn't it affect the kidneys somehow?
Loops can actually help the kidney under certain conditions. Thiazides, actually, you don't want to give them unless the kidney works, but there's one, metalizone, you can actually give in people with renal disease. And then the third one we talked about, potassium sparing. There's two groups of those. What are they? Okay, mineralocorticoid receptor antagonists. Those are steroids. There's two of them. Which one of those? Spironolactone and eplerenone. And then there's other two that are so-called ENaC inhibitors. They inhibit the sodium channel. There's, starts with an A, amiloride and Triamterene, right, triamterene. Side effects of those? Well, a triamterene can cause kidney stones. Hyperkalemia. Hyperkalemia. Now, you usually use potassium sparing diuretics with other diuretics. So usually the potassium loss and gain level out, but not always. Make sure you check potassium levels. It's especially an issue if they're on other antihypertensives that raise potassium, which we'll talk about in just a bit. Morgan?
You said there's two different types of potassium. What do you call them?
There's the mineralocorticoid receptor antagonists, which is spironolactone and eplerenone. And then there's the ENaC inhibitors, ENaC. ENaC stands for epithelial sodium channel, ENaC. And that's amilorone and triamterene. Yeah.
So are diuretics the first thing we try for?
Depends. Depends. Depends on your patient, depends on their age. It's going to depend on their ethnicity too, because some drugs work better on certain ethnicities than others. Sydney?
At what point would you give someone a potassium diuretic along with another diuretic?
If you're trying to prevent constant potassium loss and they're having trouble from constant low potassium, then you could throw in a potassium sparing diuretic, and that will tend to equalize the potassium loss. That's when you'd pile one on top of that. Okay. All right, a little bit on this, then we'll take a break. Okay, I'm going to leave the diuretics and now go to some other antihypertensives. Now, there is the renin, angiotensin, aldosterone system. You learn this in A&P, and we talked about it in pathophys. I'll give you a brief review of this. So the kidney jealously guards its perfusion rates. If its perfusion rates drop, if they drop, the kidney releases an enzyme, and that enzyme is called renin. Renin circulates through the blood, and its target is a liver-produced enzyme. So let's down here draw a liver, and it secretes proteins into the blood. One of them is a 57 kilodalton protein called angiotensinogen. Renin takes angiotensinogen and it clips the front end of the protein off angiotensinogen. So renin is going to take this and clip it. So if renin essentially, if angiotensinogen looked like this, after renin gets done with it, now it's going to look like this. Like that. This piece here is called angiotensin 1. Angiotensin 1. This doesn't have much function. However, it will then circulate through the lungs. For the lungs, I'm just going to draw a nice box here and say lungs. So in the capillary beds of the lungs, there is an enzyme called angiotensin converting enzyme. And angiotensin converting enzyme is mercifully abbreviated ACE. ACE takes angiotensin 1 and it clips a couple of amino acids off the back end of it, converting it into angiotensin 2. Angiotensin 2 is a potent vasoconstrictor. It's a systemic vasoconstrictor. So this is going to raise systemic vascular resistance. It does a second thing. This will go to the adrenal gland that sits on top of the kidney. It now stimulates this to release aldosterone. Aldosterone causes you to retain sodium. So now you're vasoconstricting. You're also keeping more sodium. That's going to raise, it's going to draw water out of cells. You're going to increase blood volume. So can you see how this substantially raises blood pressure? Essentially what the kidney is doing is it's squeezing vessels everywhere else except at the kidney. So all the blood goes whoosh, right to the kidney. That's how the kidney essentially jealously guards its perfusion rates. So, do you think this is a target for blood pressure control? You bet your toenail polish it is. And there are 3 drugs, 2 groups of drugs, and then a third drug involved in controlling blood pressure via controlling angiotensin II signaling. We'll talk about those right after we take our break. So 5 minutes, then we'll see you back here. Look this over, see if you have any questions, then we'll go from there. Guys are all so quiet tonight. You're normally also very chatty. You're not so chatty tonight. You guys lost an hour. You lost an hour last night. Yeah, you did. You're supposed to set your clocks. Did you forget to set your clock?
Our phones do it automatically. Yeah, our phones do it automatically, but usually my dad reminds me he didn't. I missed the memo.
Well, I woke up at 6:45 this morning. I was supposed to wake up at 5:45. So.
Oh,
Yeah. That's the shower I've ever taken. Because that class is simply right. You know? My understanding too now is that the pandemic is starting to wane in hospitals.
They have one co-location.
If it was that, I'm like, no, that's. Oh, we made it. It was 12 hours from last week. And we have one like 2 weeks. It's like, I think it's. I know.
Yeah, so they took one of them.
Yeah.
I kind of like pushing stuff on.
Yeah.
What happened?
So my dad's like, we might take a drive out to California. It's just lovely. What?
Okay, let's go ahead and resume. Does anyone have any questions about the renin-angiotensin-aldosterone system as very quickly explained here. No? All right. All right, so angiotensin II binds to a receptor, and that receptor is called AT1. There's another receptor called AT2, but the main receptor, at least for blood pressure purposes, is AT1. That's going to become significant here in just a bit. Yes,
Can you rewind real quick?
sure.
Okay, so angiotensin II goes to the AT1 receptor.
Binds to the AT1 receptor.
Binds to-
And AT1 receptors are found in smooth muscle and blood vessels. They're also found in the adrenal gland cells.
and that's in the adrenal.
That's the adrenal gland, yeah. That's the two main places where angiotensin II exerts its biological function. Is in the blood vessels and also in the adrenal gland. All right. Now, the first group of drugs are drugs that inhibit the angiotensin converting enzyme. And these drugs are called ACE inhibitors. They're very, very widely used group of antihypertensives. Yes? We're going to circle back to beta blockers. They decrease systemic vascular resistance, and they do so without causing rebound tachycardia. Many vasodilators will cause rebound tachycardia. These do not. That's a big advantage of them. These drugs on the average are extremely well tolerated. There's 10 of them that are listed here. Captopril is the oldest of these drugs. Captopril contains sulfur. If you have a sulfur allergy, you cannot the patient cannot use captopril. And Aliskiren comes in an IV formulation. These others basically are oral drugs. And their main indication is hypertension, albeit they can also be used for chronic congestive heart failure. So you can see here enalapril, captopril, lisinopril, fosinopril, those ones, and also trondapril, those are also used for congestive heart failure. Notice that these drugs end in P-R-I-L, pril. If you hear pril, pril, it's an ACE inhibitor. These drugs are all in generic, and most of them are very cheap. This drug, lisinopril, oh, good gracious. Generic lisinopril, a month's supply of generic lisinopril is $2. It's very cheap. Most of these others are equally as cheap. They're not at all expensive, and they work. They work. So, because they inhibit the release of aldosterone, a potential side effect of these is hyperkalemia. Now, if your patient stays hydrated, that's usually not that big a problem. But if they tend to be dehydrated, that may also be an issue. Also, if they're on other drugs in combination with these that raise potassium levels, then hyperkalemia becomes a genuine problem. About 20% of patients on these will also get a dry cough. There's reports of GI disturbance, but they're very uncommon. And patients who complain about GI disturbance, it goes away. And it tends to go away pretty quickly. So GI disturbance is not really recognized as a common side effect. The other thing you'll see with these drugs is something called a first dose effect. And with the first dose effect, the blood pressure will tend to drop really substantially after the first dose, and the patient will get this condition called orthostatic hypotension. You heard of that before? So that's common with many different types of antihypertensives. ACE inhibitors will tend to do that. Usually at the first dose, once they get used to the drug, that usually goes away. So when you tell your patient, if they report either postural or orthostatic hypotension, you tell them to get up slowly. So swing their legs, put their feet together, hold on, get up, pause, and then stand up while still holding on, then let go. That's usually the way you tell them how to get up. Okay, no wisecracks. Now, some patients will have a very high level of another vasodilator in their bodies because renin also targets another peptide that lowers blood pressure. This peptide is called bradykinin. So renin will degrade that, but if you, no, ACE will also inhibit bradykinin. I'm on the wrong side of the page here. And if you inhibit ACE, bradykinin levels can really soar in some people, and they can get this condition where their face turns really red, and they get a movement of fluid from the blood system to the extracellular system, and their blood pressure drops abnormally, and that's called angioedema. Not common, but if it occurs, it's a medical emergency. You'll see it in the face and neck. You'll see it soon after they take the dose. Question, yes? Bradykinin is another blood-borne peptide, and it's a vasodilator. So with ACE inhibitors, you get a twofer. You get less angiotensin II, and you get more bradykinin. That's why ACE inhibitors can drop your blood pressure pretty substantially sometimes. Emily?
So, sorry, I'm trying to think. For bradykinin, is the swelling all like their blood pressure is getting lower, but it's because all the fluids are leaking?
Right, you're getting divergence of fluid to the extracellular spaces.
Okay. And does that happen like all the time that you're on an ACE inhibitor?
No, only certain people. This is one of the severe side effects of ACE inhibitors. It's very uncommon. It's also certain people are more sensitive to it. If you see this, you pull the drug ASAP and you send them to the emergency room because they're going to need fluid support.
Is that going to be like an airway?
Potentially. So that's the one severe side effect. Coughs are usually annoying, and the cough is usually due to increased bradykinin as well. All right, any questions about the, yeah, Clarissa? Yeah. with caution. Digoxin has a very narrow therapeutic window. And so you have to be careful about the excretion of digoxin. So you can combine the two. Digoxin also is very sensitive to potassium levels, digoxin activity. So if you put those two drugs together, you have to do it with caution. Digoxin is for heart failure. We'll talk about that when we get there. All right. Angiotensin II receptor blockers. Angiotensin II receptor blockers, or ARBs. So these are AT1 receptor antagonists. They bind to the receptor, they do not elicit a biological response, and they prevent angiotensin II from binding to the receptor. These end with sartan. Sartan. So as whereas ACE inhibitors end in pril, these end in sartan. So low sartan, ARB sartan, Candide sartan, tell me sartan, your mother-in-law sartan. Those are all ARBs. Yes?
You said they're agonists or
Antagonists. Antagonists. They block the receptor from doing its job. So there's 8 of these. All of these are off license except for azilsartan. Azilsartan is the newest. That's still on license. The rest of these are available in generic. They tend to be more expensive than ACE inhibitors. Also, typically, you will use an ACE inhibitor first, and if an ACE inhibitor is not tolerated, then you go to these. The cough is less pronounced with ARBs. Also, angioedema is much, much, much less common with ARBs as well. Hyperkalemia is still a possibility, but again, if you hydrate, it's usually not an issue. These drugs are extremely well tolerated. These drugs are oral. I think valsartan comes in an IV form. And I think it's used. Let me check that really fast. I don't know if I'm lying to you, but I vaguely remember no, IV form was discontinued. So these are oral. All these are oral. Now, with these drugs, your patients can take them with or without food, but they have to take them the same time every day. Same time every day. With or without food, doesn't matter, but take them at the same time every day. Now, the new kid on the block is this drug, Aliskiren. This is a direct renin inhibitor. This drug has a very long half-life. And in addition to hyperkalemia and other things like that, this drug usually can be hard on your GI tract. So this drug is usually only used if all your other options really don't seem to pan out. This drug is very new. There's just not a lot known about it because it's so new. Aliskiren. All right, so if I ask you, ACE inhibitors, ARBs, aliskirins, they decrease blood pressure by A, decreasing cardiac output, B, decreasing systemic vascular resistance, C, increasing cardiac output, D, increasing systemic vascular resistance. Your answer is A, decreasing cardiac output, wrong. B, they don't affect cardiac output. They affect systemic vascular resistance because they cause vasodilation.
You gonna ask that quiz tomorrow? We should.
There is no quiz tomorrow. Wednesday? Okay, now let's circle back to the beta blockers. All right, to introduce the beta blockers, let's just review very briefly the sympathetic nervous system. So your nervous system is divided into that's meant to be a brain, that's meant to be a spinal cord. So this is the CNS, and then also nerves that come from the CNS and then go to various places. That would be the PNS. So you have the central nervous system and then the peripheral nervous system. And the peripheral nervous system is broken into two main parts. So there's a somatic nervous system. And the somatic nervous system is going to consist of motor neurons that innervate skeletal muscles. And those are muscles over which you have conscious control. Then there's the autonomic nervous system. And the autonomic nervous system is broken into two sub-branches, the sympathetic and the parasympathetic. And the sympathetic nervous system is involved with the fight or flight response. And the parasympathetic nervous system is associated with the rest and digest response. So let's say our dear friend Natalie is walking home from the library and she hears a rustling in the bushes and out comes a Spring Arbor cougar. And so Natalie says, "Go away, kitty." And she throws her binder at it, throws her whatever at it, and then makes lots of noise and goes bark, 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 or something like that to scare it. All the time, though, she's scared out of half her wits. So let's think about what happens. Her heart rate goes up. Her eyes are going to dilate. Her bronchial tubes are going to relax and open up to get more oxygen. And her liver is going to release glucose for fast energy. All of those are functions of the sympathetic nervous system, fight or flight. Natalie, in that case, chose to fight because she probably couldn't outrun a cougar, but I'm just guessing. I don't know, maybe she could, hard to say, I'm just guessing. So she could, oh, okay. Then maybe she should have gone the flight route. Okay, anyway, either way, the sympathetic nervous system is the one that would have been activated. Now, Natalie gets back to her apartment, dorm room, whatever. And she lies down and goes, and then she takes her phone and puts in her Ray-Bans, and she listens to some tunes. And she Ray-Bans are ear, you know. Raycons, sorry, Raycons. Raycons, the other ones. Raycons, and she listens to some tunes, and she sips an iced coffee or something. Now that's going to be the parasympathetic nervous system, the rest and digest. The rest and digest. So remember, autonomic nerves. They consist of two neurons. One has its cell body in the central nervous system. That cell body is then going to extend its axon to the peripheral nervous system. That is the preganglionic. And then that will synapse with a postganglionic neuron. That postganglionic neuron releases norepinephrine, and to a lesser degree, epinephrine. And then epinephrine and norepinephrine will bind to adrenergic receptors. Come on, you. Natalie, thank you for being a good sport while I pick on you. Okay, adrenergic receptors. There are two main types of these. There's alpha and beta receptors. So there's two main types of these beta receptors. There is a beta 1 and there is a beta 2. And then the alphas, there's an alpha 1, an alpha 2, and then as it also turns out, there's an alpha 3, but we won't worry about that. Now, let's concentrate just on these beta receptors. So the beta 1s, they're found in the heart. And they're also found in the kidney. The heart and the kidney. When they're activated in the heart rate goes up, and the force of cardiac contraction also goes up. Force of cardiac contraction also goes up. In the kidney, when you activate them in the kidney releases renin. So we can see activating beta 1 receptors is going to pretty substantially raise blood pressure, isn't it? Beta 2 receptors. Where might beta 2 receptors be found? Well, they're found in the smooth muscle of the lungs and the bronchial tubes. They cause bronchodilation. They're also found in the ciliary body of the eye. And if you activate these, you secrete more aqueous humor. They're also found on some peripheral vessels, the smooth muscle of peripheral vessels, particularly those, so blood vessels, those that service the skeletal muscles, and also the brain. Then you also have beta-2 receptors in the liver. Activation of these in the liver causes the liver to release glucose. And they're also in the pancreas. You activate them in the pancreas, you cause pancreas to release glucagon. And then they're on endothelial cells, and beta-2 receptors will activate lipoprotein lipase. Lipoprotein lipase causes serum lipoprotein particles to leak fat. So they actually help degrade fat that is in the serum so that peripheral tissues can take up fatty acids and use them as carbon and energy sources. This beta-2 receptor is pretty busy. Now, if you understand the function of these two receptors, you're going to completely understand the side effects of beta blockers. Guaranteed. Guaranteed. So, beta blockers come in three types: non-selective, cardioselective, and those that have a vascular dilation function. Now, for the non-selective, let's do the non-selective first. Our mnemonic for this is going to be New Zealand. So if drawing a kiwi or something like that will help you remember this, please do so. Why New Zealand? Because non-selective beta blockers begin with the letters N through Z. They begin with the letters N through Z. So on your handout, you'll notice that those beta blockers have names like nadolol, sotalol, pendolol, propranolol, and notice they end in LOL. LOL. So remember this: high blood pressure is no laughing matter. Because because beta blockers end in laughing out loud. So these are the comedians of the antihypertensives. But high blood pressure is no laughing matter. These begin with N through Z. Nadolol, sotalol, pendolol, propranolol. Propranolol is the most lipid soluble of these. This crosses the blood-brain barrier Therefore, this drug is used to treat migraine headaches. And it's fairly effective for that. It's also used when we talk about lithium. We'll see that one of the side effects of lithium is essential tremor. Propranolol can treat the essential tremor in people on lithium. So it's also used to treat essential tremor in lithium. So with non-selective beta blockers, you get a low heart rate. That low heart rate can cause bradycardia. Bradycardia. With the bradycardia, you will also get fatigue. Fatigue. Because you're blocking the beta 2 receptor 2, you may have some bronchoconstriction and therefore wheezing. Therefore, these drugs are contraindicated in people with asthma or chronic obstructive pulmonary disease. Because they don't allow these vessels to properly vasodilate, they can cause sleep disturbance and even nightmares in some patients. That's mainly the case with propranolol. Others can cause this. It's been reported, but the big offender here is propranolol. They can cause low blood sugar. And because hypoglycemia tends to be presaged by tachycardia, these will shield, they'll obscure the tachycardia that normally shows that your patient has hypoglycemia. Therefore, these types of drugs should not be used in patients who are diabetic. And then, because they affect LPL, they can raise serum triglyceride levels. So they can cause hypertriglyceridemia. Those are the non-selectives. Got about a minute and a half left. Let's talk now about the cardio-selectives. Our mnemonic is armadillo, because these begin with A through M. Armadillo. So they include drugs like atenolol, bisoprolol, metoprolol, esmolol, acetabutalol, and so on and so forth. These drugs have a very high affinity for the beta 1 receptor relative to the beta 2 receptor. So they are safe for use in asthmatics. They're also safe for use in diabetics. They don't tend to cause a sleep disturbance you see in the non-selective ones. These are used mainly for hypertension. Metoprolol and bisoprolol have been shown to be useful in congestive heart failure. Their use in congestive heart failure is controversial. Some cardiologists are convinced beta blockers make the congestive heart failure worse. They are also used as an antiarrhythmic. They're quite good for things like atrial fibrillation or ventricular tachycardias, things like that. And they're good for stress induced hypertension. And they're also quite good for angina pectoris. With angina pectoris, you get this crushing pain underneath the sternum because you have a mismatch between oxygen demand and oxygen consumption of the myocardium. Big side effect with these is fatigue. Okay. Wednesday, we'll finish beta blockers. Then we'll go to the alpha blockers and the central adrenergic blockers, which really aren't used that much, but they are used for ADHD mainly. And then we'll go from there and we'll look at treating congestive heart failure and then treating angina and then treating coronary artery disease. I will see some of you tomorrow